Next slide, please. Okay, so my patient is 62-year-old JKO, male patient from Kindu Bay. He presented with nodular swellings that have been present on the face and the scalp. Initially started as pruritic rashes and are managed severely with antihistamines and topical corticosteroid creams. Treated also for leprosy at some point, but cannot remember the exact date. When the swelling started getting nodular, a biopsy of one of the lesions was done. A biopsy of one of the lesions was done, and this was approximately the swellings have been there for the last 3 months. So this was a biopsy of the result of the biopsy of the first that was taken for the first time, and it showed that features were suggestive of mycosis fungoides, and it required immunohistochemistry to confirm diagnosis. So the next slide. So this was the immunohistochemistry results that showed that the CD3 was strongly and diffusely positive, CD20 was negative and highlights reactive B cells, CD4 was strongly and diffusely positive, and then CD8 was negative. So this was shown to be morphological features that were consistent with mycosis fungoides stains. Next slide. So this patient is a nutritionist by profession. Serostatus is non-reactive. He is not hypertensive nor diabetic. No familial history of carcinomas or any other chronic illnesses. Past medical history, there was nothing that was of much concern. No food and drug allergies, and systemic review was normal. Next slide. So examination, there's an elderly male patient at ECOG1, not pale, no jaundice, no cyanosed, and those are his vital signs. Other systems were essentially normal. Next slide. So these are the photos of the patient, the way he looks like. So this is the largest that's on his left side of the face. The next one. The back and the scalp not so visible, but that's how the back area looks like, and the scalp also, the back of the scalp. Next slide. Next slide, please. Front part of the face. Next. More lesions. Slide. Next slide. Yeah. So the tests that have been done so far for the patient is an abdominal pelvic ultrasound that showed normal findings. Chest X-ray also was done, was normal. Was sent for a CT scan of the chest, and those ones you're waiting the results. This was his full blood count. That just showed monocytosis, slightly reduced full blood red blood cells. Hemoglobin also slightly on the lower side, and yeah, that's basically it. Next slide. So why decided to bring up this patient for discussion was so that I could be assisted with this mode of management. Should we try interlesional chemotherapy? Should we go for the CHOP regimen? Should we think of doing radiotherapy to some of the lesions, and any further additions if they would arise? Thank you. That's for the first patient. Yes.
So just a question for the lesion. For how long have they been there?
The lesions have been there for approximately 4 months. Hello, can you hear me?
Yes, I can hear you.
Yes, they've been there for approximately 4 months.
So, okay, from my point, I think this could be a dermal issue, and especially the mycosis fungoides, as you have said. Have you But is this the first time? Have you ever tried any treatment?
Have I ever?
Have you tried any treatment on this patient?
No, no, no. This is the first time he's presenting for anything related to cancer.
Okay, thank you.
Hello? Morning, I really can't get whatever you're saying.
I think we are waiting for the input from any other person.
Mhm. I'm sorry, is anyone speaking? Because I can't get anything.
There is no one speaking yet. I think they are doing a little bit of consultation. No one actually is.
Oh, okay.
Hello,
Hello.
Doctor. Doctor Eve, we don't have so much experience with mycosis fungoides. I think we only had one patient here, and
Okay.
one thing to note is that this most of the time the mycosis fungoides is cutaneous T-cell lymphoma, and one
Mm-hmm.
thing to note is that it has no cure. Most of
Okay.
the treatment that we give is for symptomatic relief and
Mm.
reduce of the lesions. So
Mm.
what we have seen here play a role is high-dose methotrexate.
Mm-hmm.
I think for the patient we had, we gave him around almost 2 grams, and it goes up
Mm.
to 24 hours. And for high dose methotrexate, because of the side effect of mucositis, you always have to
Mm-hmm.
with leucovorin so that they don't get the side effects because can be very severe. So it helps
Okay.
to reduce the skin lesions. We
Mm.
never ever talked about any radiotherapy unless we
Mm.
thought about radiotherapy to see if it can help. Yeah,
Mm-hmm.
but high-dose methotrexate worked for the patient.
Okay.
Any other input?
All of the therapy focus would have been of much help, but since he'll join later, we can consult him on that, and then we'll relay the feedback. But
Okay.
the patient I can see it was CD3 positive. Okay.
Mm-hmm.
As Dr. Caroline have said, we don't have much experience with that, so maybe we can ask further, and then we can give you the feedback.
Okay.
So we can go to the next. Okay, I think we have a presentation now. You can continue.
Okay, so the next slide is one for Kaposi sarcoma. So this is a 30-year-old female LAG who came in with who's presented with an oral swelling for the last 6 months. So this patient is seroreactive on TDF, 3TC, and efavirenz plus cotrimoxazole since September 2017. Her latest CD4 and viral lows are unknown. Of note is that she has undergone 6 cycles of gemcitabine 2 weekly, was initiated on the 15th of March 2018, and got the last cycle on 7th of June, this 2018. So this Kaposi sarcoma was diagnosed through a biopsy of the oral lesion. So next slide. Past medical history, she'd been admitted at JOTRH in February of this year, was treated for bacterial pneumonia, for PCP, and oropharyngeal candidiasis. Although gene expert for MTB was done and it wasn't detected, the patient was treated for TB based on chest X-ray findings. Next slide. The patient was seen in oncology clinic for the first time on the 15th of March 2018 and worked up for 2 weekly ABV regimen for 6 cycles. But then this was changed to BV because of an echocardiogram of the heart that showed that ejection fraction was 70%, and she had massive pericardial effusion and a trace of mitral regurgitation and tricuspid regurgitation. So the BV was ultimately not given because of funds, and thereafter was prescribed gemcitabine 2 weekly for 6 cycles at 1,200 milligrams per meter squared. Next slide. So this was how she looked like before the chemotherapy was initiated. The lesion actually was filling the whole lower jaw. Next slide. So as per the last time she was seen, I don't know if it will be if it will be visible, but that's how the lesion looks like. It's markedly reduced down in size. Next slide. So why I brought her up for discussion was that should we still continue with chemotherapy? Should we stop it, or should we change to another line? And now that this mass has really shrunk down, is there really any role for excision for the mass? And if there are any other additions, we could also accept those. I think that's the end of the discussion.
After the chemotherapy, can you say the patient has a complete remission or a partial response, according to your assessment?
I'm thinking it is complete. Hello?
Yes.
Yes. Complete. Hello?
Hello, can you hear me?
Can I?
I'm saying,
Yes.
yes, I'm thinking that's like gingival hyperplasia. Do you think it's still KS?
I think it might still be KS. I'm thinking it's still the KS, yes.
Okay, in our setup, after the patient, okay, I can see he has done a gemcitabine, he went on to BV, and in my opinion, you say that is a complete remission. So if you think the patient has a complete remission, I think we can observe. We can do monthly follow-ups, and then we see how she responds. But if you think those lesions, they are not responding to the chemo, they have not reduced since you gave the first chemo, you can refer the patient to us. Currently, we are using pegylated liposomal doxorubicin for these patients who are not responding, or we are giving them paclitaxel. So if you think the patient needs chemo, I think you can send the patient to us. We have liposomal doxorubicin.
Hello?
Yes, I see that.
Hello, morning.
Good morning.
Yes, good morning.
Alright. Yes, I'm sorry, follow up.
Hello?
I left off at monthly follow up. Was there any other that was added?
I don't think monthly follow-up is a good idea because the tumor is still there. Are you going to change? Are you going to start another chemotherapy? That's the question you should be answering. Koila, you're still there? Hello?
For this patient, since we've given cycles of gemcitabine, I would like to ask Dr. Koile, are there any other side effects maybe, or is the patient on follow-up with the treatment, does she have any side effects on gemcitabine?
None that was seen. She actually tolerated all gemcitabines very well.
Okay, for this patient.
Hello?
Hello?
Yes?
For this patient, since he has not gotten the maximum cycle of the gemcitabine, I would
I
recommend.
can get you.
Can you hear me?
Yes, I can.
Yes, I'm saying. Or am I too fast?
No, you're not.
Okay. So
Just say what you say.
the patient has gotten six cycles so far, right? So we'd recommend
Yes.
to continue with the cycle. So you can give up to 8 based on response. If not, you can
Okay.
give up to 12. Then if there is no response, then you can switch to another regimen.
Okay. So.
Any other input from the team? So if none, I think we can go to the next presentation.
Okay, so this is the last presentation from my side. This is a patient with a carcinoma of the cervix who had carcinoma of the cervix.
Hello?
Hello?
Yes, I just like to put just a comment before you start on the next presentation. So we have a current study that is ongoing. It's called a PD-1 study. So it's on KS patients, those patients who have undergone BV before, then disease came back, switched to gemcitabine. They have done full cycles of gemcitabine, no response. So we're starting them on pegylated liposomal doxorubicin, and we're giving them for free. So if you encounter such patients and whom you think they're not responding to the chemo given, you can refer those patients to us. We'll take care of them. Thank you.
Okay. So next slide. So we have this is a 51-year-old female patient from Maragoli, LAP, was diagnosed with CS cervix in 2014, and this was a poorly differentiated squamous cell carcinoma of the cervix. Was done for hysterectomy plus bilateral salpingo-oophorectomy, and then underwent radical chemoradiation, EBRT plus brachytherapy and concurrent cisplatin at Mulago Hospital. In early 2016, during subsequent follow-up, an abdominal MRI was ordered for and a bone scan was also done, and this revealed there's the next slide. So this was the abdominal MRI. This showed it was of normal findings. The next one. Next slide. Setting a pelvic okay. Now a bone scanning was done that involving the region of the left femur. However, the rest of the skeletal survey was essentially negative for skeletal metastasis, and this was in 2016. Next. So with that pelvic scan, it was done for radiotherapy to the pelvic.
Sorry, Dr. we can hardly hear you. I think your network is fluctuating.
Oh, okay. So I'm saying with the bone scan that revealed the lesions at the intertrochanteric area, the patient was then done for radiotherapy to the pelvic joint. So next slide. So that was in 2016. Then in 2017, another repeat bone scanning was done that still showed the demonstration of features consistent with skeletal metastasis involving the intertrochanteric region with mild increase of disease activity. So the increased stressor uptake in the left maxillary sinus is consistent with the, okay, I can't read this other part. I can't read that part, but again, it just showed that the features that were still consistent in 2016 were still found in 2017 in the bone scan. So next slide. I think that's the same one that we've had before. The next slide. So in May 2018, the patient now presents with a unilateral lower limb swelling, and that was started on warfarin and aspirin at a peripheral facility. So a Doppler ultrasound was ordered for, and this showed features of chronic plaques causing narrowing of the lumen of the femoral, common popliteal and superficial femoral vein with a popliteal cyst. After further consultation, it was discussed that in very rare situations, the CA cervix metastasized to the bone, that this could actually be a different disease pathology altogether. So this patient was then asked to go for a CT scan of the chest and a CT scan of the abdominal pelvis with contrast. This was to be histopathology to see if this was actually another disease pathology. So on the part of the warfarin and the aspirin, the patient was just continued on the warfarin. So next slide. So this was the CT scan chest that was done in May, and it showed was a left apical lobe pneumonia. Next slide. Now an abdominal pelvic CT scan that was done showed the normal post-TAH abdominal pelvic CT scan with the right iliac wing focal sclerotic lesion, likely bone islands. Next slide. So with the outcome of the two CT scans, the pathologist was consulted and advised that how they would get a biopsy for them from the area was through an open bone biopsy. The patient was then informed of the outcome, but she was not for the idea of going in for surgery. So next slide. So now the pointly, the patient was also advised that in case of a recurrence of the tumor, we are stuck at where to now. Any other addition, it would, if they're there. I think I'm done. Hello?
Yeah, we are there. We're listening.
Yes. I'm done with my presentation. So we
What?
input.
I have a question about the female lesion from X-rays. Is there like a pathological?
Yes. Pardon, please?
I was asking whether from X-rays of the female lesion, are there like features of a pathologic fracture?
Mm-hmm. Okay, now sorry, but you haven't done any femoral X-ray to the lesion, yeah.
Good morning.
Morning.
This is Dr. Tonui from Eldoret.
Yes.
Bone metastases from cervical cancer are not that common, but they do happen. Usually, generally, distant recurrences of cervical cancer would generally go to the liver or the lungs. But bone metastases are observed. We generally see, especially the lumbar spine. I think the long bone metastases are a bit more rarer, but it can happen. So it could be interesting to get and if it does confirm that it is squamous cell carcinoma, then I think we should then cancel the patient on palliative nature of the treatment. They don't usually do very well when we have distant metastases.
Hello.
Yes.
Hello.
Hello.
Yes, we can hear you.
Oh, you can hear me now. My issue is, what is your threshold for treating a metastasis to the bone? As in, do we say that if we cannot get a bone biopsy, then we should not treat? Or what would be your view about that? Because sometimes, especially when we're talking about lumbar spine or some of those pelvic bones, getting a biopsy of the bone means that you might have to open the patient, and the patient might be unwilling to do that. So I don't know what is our threshold for treating, even from the radiological point of view. Do the radiation oncologists always have to get a biopsy?
Well, maybe our imaging colleagues can guide us if there are like characteristic features of a cancer process on the bone. But it wouldn't be nice treating lesions on the bone that we are not sure they are cancerous. That would be my opinion.
Okay. Thank you, Tony. I don't think any other person will contribute once Tony and has spoken, unless the other people contribute.
that should not be the spirit at all.
I think Dr. Tanui gave the expert opinion there. I think is the most qualified person around here to give that kind of opinion. So I think we'll abide by that.
Yeah, because I think that the other person who could have given an opinion is the radiation guy, as Tony has said.
Yes.
Maybe Opakas or some radiologist maybe would give an opinion also.
Sure. But aren't there any other ways of getting a biopsy apart from open surgery? Like,
I don't know about the bone. I don't know.
I guess about the biopsy, there are different options. As someone had suggested, would probably like an image-guided biopsy, like a core biopsy. But that would
Core biopsy of bone?
no. I'm saying that would largely depend on the nature of the lesion itself. Is like from the imaging findings, is it like a osteoporotic or like a soft tissue thing eating the bone? Because again, we have had the interventional guys getting nice like biopsies from spinal lesions, but when there's a predominance of tissue component, but as long as it's just bone, they might be no like any other option. And then again, the other challenge about going for an open biopsy is, especially if it's a stable like bone lesion, you might actually cause a iatrogenic like fracture, which again complicates the whole issue.
Okay.
so I think, Craig, if you are in a very tight corner, the patient is not willing for an open biopsy. I'm sure you don't have radiation in Kisumu. You might want to give a chemo, like and measure if it is responding. I don't know. But after talking clearly with the patient, for sure.
Okay, thanks for that.
Yeah.
Great. I think that would be it from our side.
Okay, thank you, Kisumu team, for presenting wonderful cases. I have some few announcements to pass across. So we want the cases to be sent by Thursday evening so that we can mobilize, we can invite the consultants so that we can have various inputs from various departments, because these cases we are getting late and inviting consultants is becoming tricky. So we want to improve the tumor boards. We see it's educative. We're also improving the care given to the patients. So let's try. I'm sure these cases have been there for weeks in the wards. So if by Thursday we can have all the cases so that we can invite the needed consultants, that will be awesome. Otherwise, thank you and good job.
Thank you.
So we are having one more presentation from this end. So I'm Adalbert Omwamba. I shall be presenting a patient by the initials PAO, 38-year-old female from Kisumu, admitted on the 4th of June. So she presented with a breast mass that has been there for 2 years, 1 day of vomiting and 1 day of fever. So the patient is a non-RVD on heart who presented the above complaints. She supposed to have developed a mass on her right breast in July 2015, which was increasing in size, and biopsy done and was diagnosed of pilous tumor, and mastectomy was done at URTH in 2015, but a new lesion started to grow in January 2016, and has been growing since then. 2 months ago, it started bleeding, and there was also discharging pus. So on the day of admission, she presented with vomiting, which was non-projected and bilious in nature, and had also lost appetite and had was having hard stools. Also had fever on and off associated with an headache. There was no history of dizziness or blurring of vision. So past medical and surgical history, she has been previously admitted at URTH for the same complaint, and I had mastectomy done. There was no history of blood transfusion, no history of drug allergy. She's married, sells vegetables for a living. She's a casual laborer and does not smoke or take alcohol, and she's an HIV contributor. So on examination, she was in a fair general condition. She was not pale, not jaundiced, not cyanosed, not dehydrated. She was febrile. She had no lymphadenopathy, and she was not edematous. ECOG, she was at 2. Vital signs were all normal. Local exam, there were 2 large masses arising from the right chest wall. The first was measuring about 30 by 20 centimeter, and the second one about 12 by 15 centimeter, with a friable mass in between. And it was smooth, firm, and irregular in shape. There were no palpable axillary lymph nodes. Left breast was present. There were no areas of discoloration, no masses, no lumps. There was no nipple discharge, and no palpable axillary lymph nodes. So that's the photo. That's how the 2 masses look, with a friable mass in between. Stomach examination, respiratory exam was essentially normal. CVS and abdominal examination were essentially also normal. So that is the histology report from the first mass, which showed a phyllodes tumor. And this one was the second histology report taken in this hospital, also showed a phyllodes tumor. These are the UEC's, the CBC results. Showed iron deficiency anemia. These are the UECs. They are essentially normal. These are the CT scan slides for the chest and abdomen. The report showed the recurrent breast mass, large masses. The largest measuring 14.52 by 13.87 by 14.7 centimeter, and the other one was 8.73 centimeter by 8.34 centimeter by 10 centimeter. So point of discussion is the best way forward for management of this patient, considering that the patient had a mastectomy with no adjuvant therapy thereafter, and currently the patient is only on best supportive management. Thank you.
So my I have a few, like from the previous surgery. She said she had mastectomy. I think there's quite a bit of missing, like information based on previous surgery. Like from that time, what was the tumor size, like of this breast that was removed? the diagnosis if it was phylloides, what is the nature of the phylloides tumor? Because we usually grade phylloides tumor is not like one diagnosis. You grade them based on its malignant potential. You can have a benign phylloides tumor, you can have a borderline phylloides tumor, then you have a frank malignant phylloides tumor. So again, that mastectomy specimen would really have yielded a lot of information because the way you handle malignant phylloides is quite different from like a benign phylloides or a borderline phylloides tumor. And then again, we are not sure about the status of the margins. Like, was it like negative margins or even lymph node status if they were there? And given that, anyway, with this kind of presentation, from the way it looks, it almost points towards phylloides, more of a malignant potential, like a malignant phylloides tumor. But at least if it's not benign, I would say, because benign phylloides tumor will not be this aggressive. Any information on the previous mastectomy?
So we don't have a lot of information, but what I was able to gather is that the tumor regrew barely 3 months after excision, and she reports that the initial tumor was larger than what she currently has. That's what. Maybe you can get more information from the RTH. That's because that's where the surgery was done.
If I can comment about that, so unfortunately, the sample was taken to Aga Khan, but they told her it was not stored properly. So they did not do any histological reading on it. So it was an issue of storage. So we lost that chance. Yeah.
I think eventually, like the way forward probably would be, given the size of the lesion and the ulceration, might need like a surgical review and probably surgical excision of the whole thing with hopefully can get negative margin. But then the challenge again, I guess surgeons really have to review because how will you close the wound?
They are all for neoadjuvant if you think it's malignant. Yeah.
Yes, a malignant phylloides is literally a high-grade sarcoma.
So you can give neoadjuvant.
Any input from any other person? I don't know if you have been getting us. Eve, Caroline.
Yes, you can get you.
So have you been getting us?
Yes,
Yes,
we have.
yes. Yes,
Okay.
yes. Mm.
So any other input? So I think if none, I think we will stop there for today. And as Dr. Kisilu has said, let's try and get these cases by Thursday so that we can share and we can actually get more input during our discussions. So this week we will try as much as possible to get the cases and share by Thursday evening so that we can have good time to review them.
I think someone else commented, you're not giving away forward for this patient. So she's currently in the surgical ward, so we'll see what the surgeon's input is. From our team, we had suggested to give some neoadjuvant so that if we can get good margins and debulk the tumor. So we'll see what the surgeons have said about if they could do the surgery and if they can take our input about the debulking the tumor. Yeah.
So I think we'll stop at that point. Thank you very much for attending this tumor board. I think we'll keep improving and let's keep time. Let's be there at 8 so that we can have more time to discuss these cases. Thank you very much. Let's meet on Monday.
Hello.
Yes?
Hello.
Yes?
Yes. No. Yeah. Before we end,
Yes.
I wanted us to revisit the KS case.
Okay.
Yeah. In our case, then this some NCCN is putting paclitaxel or liposomal doxorubicin as our first line. But in this case, in our setting, we are using gemcitabine. They are using gemcitabine as the second line. So what will be the order of events as we are using, as we are managing KS in our setting here? Are we going to be using gemcitabine as first line, or what will be our first line as moving forward?
Okay, I think those are the new guidelines which have been published by NCCN. So ideally, vigilated, liposomal doxorubicin is the first line alternative to paclitaxel. Then if that does not respond, then you can go to second line, the sort of gemcitabine, vinorelbine, and others. So the issue actually in our setup is usually the cost, because one vial of doxorubicin, I think it's 2 milligrams, so it's like 32,000. And then one patient gets 2 vials, that comes to 64,000 per cycle. Then they get 6 cycles. They may go 6 cycles, so it's a lot. So the challenge is the cost. So if they can afford, you can go ahead. And but in our setup here at the MTRH, we are lucky. We are having the doxorubicin. So in other setup, I think the cost issue is the challenge. So the key, I think, we'll have to customize to the setting. So I don't know how to recommend on that. So depending on the cost, if the patient they can afford or not, I think that's the biggest elephant in the room to tackle.
Okay, so this is applicable to all KS patients regardless of the serostatus, huh?
Yes.
Okay. So just a last comment. We had given an input that we go up to 8 cycles of gemcitabine. But then as we go along, I just wanted to comment that as healthcare workers, then at that point, we will just be looking for the rate limiting step for gemcitabine. And that is lung toxicity and myelosuppression. So if that sets in, then we do not continue with the administration of drug. Yeah, thank you.
Okay, thank you, Dr. Caroline, for your input.
So I think we will stop there for today. Thank you very much. I think we'll try as much as possible to get to the presentations by Thursday evening. Thank you very much. Have a good day.